Good afternoon. My name is Danielle Wilson, and I'm going to be presenting to you today the mid-range theory of comfort. The theory of comfort was developed by Catherine Kolkhaba. She was born in Cleveland, Ohio in 1944. She received her first nursing degree from St. Luke's Hospital School of Nursing. She graduated from Francis Payne Bolton School of Nursing shortly afterwards. She developed the theory of comfort in the 1990s. Catherine Kolkhaba earned her PhD in 1997, as well as a Certificate of Authority as a clinical nurse specialist. She spent a lot of her time as a nurse caring for gerontology, long-term care, and comfort studies. Catherine Kolkhaba developed this theory because on most of her hospice patients, she felt like some of the care she was delivering was undefined. She felt that hospice nurses needed more recognition. She created a concept analysis of comfort first to decide if this was the right term for the care she was delivering. She turned this concept analysis into a theory. Her theory not only defined her hands-on emotional care, but encouraged other hospice, long-term care, and many other nurses to use the same comfort care. The theory of comfort is classified as a mid-range theory. A mid-range theory has criteria. These criteria include specific concepts. The theory must be readily operationalized. The theory must be adaptable to a wide range of practice and experience. The theory must be outcome-oriented. It must describe sensitive phenomena. And it must be concrete and easily tested. The theory of comfort meets all of these criteria. Catherine Kolkhaba used four theoretical sources to aid in the process of developing her theory. The first is Murray's theory of the human press. She also used Orlando's work on relief, Henderson's work on ease, and Patterson and Zerdad's work on transcendence. Catherine Kolkhaba developed her theory and mainly published them in journal articles. These are the primary sources. The nursing paradigm is recognized easily within the theory of comfort. The person, patients have needs that need to be met in order to allow them to perform at the highest level of functioning. The environment. Patient needs are heavily based on societal norms within the community and cultural politics. Nurses manipulate this environment to enhance comfort for the patient. Health. The health needs of the patient vary as the state of health in which the patient is in changes. And last but not least, nurses. Nurses effectively provide comfort care to the patient to create optimal situations and positive outcomes. In turn, patients have higher satisfaction rates, successful continuation of care, and increased financial support for the institution. There are 7 major concepts and definitions used heavily within the theory of comfort. The first is mid-range theory. Mid-range theory is concrete and can be tested. It is adaptable, and it contains few concepts and relationships. Comfort. Comfort is the state of having basic needs met for ease, relief, and transcendence. Healthcare needs. Healthcare needs are needs that arise for patients in stressful health situations. Nursing interventions are the commitment by nurses and institutions to promote comfort care. Intervening variables. Intervening variables are things that might change healthcare outcomes. Health-seeking behaviors. Health-seeking behaviors aid in bettering outcomes for patients, decreasing lengths of stay, improving functional status, better response to therapy, faster healing, and increased patient satisfaction and peaceful death. Institutional integrity is the quality or state of healthcare corporations being complete, whole, sound, upright, honest, and sincere. These concepts and definitions help to define this theory. Catherine Kolkaba came up with 4 major assumptions. Patient satisfaction is achieved if nursing interventions are successful and comfort is enhanced from the previous baseline. Patients treated with comfort care from nurses practice more health-seeking behaviors and therefore have positive health outcomes. Health-seeking behaviors increase patient satisfaction, create successful discharges, make better cost-benefit ratios, and therefore directly influence institutional integrity. An increase in comfort indicates decreased tension and constructive behavior, leading to more health-seeking behavior. Catherine Kolkaba asserted things when making this theory. These assertions include: humans respond holistically to enhanced stimuli. Comfort is a desirable outcome for patients. Human beings are active in meeting their own needs. Nurses design interventions to boost patient satisfaction. Nurses provide comfort measures to patients in need. Here's a short summary of the theory. The theory states that in stressful situations, unmet needs can be met by nurses. Humans have holistic responses to stimuli, and comfort is a positive outcome in nursing. Humans all desire comfort. Nurses perform interventions, and comfort is enhanced. This allows for more participation in health-seeking behaviors and higher patient satisfaction. Comfort is a concept that is achievable for patients with the help of the nursing staff. Comfort independently drives positive patient outcomes. The concepts and schematics model is shown here. Healthcare needs are changed by nursing interventions. Nursing interventions are altered with intervening variables that change patient outcomes. Different patient outcomes change the comfort level of the patient. The comfort level of the patient determines health-seeking behaviors. Health-seeking behaviors increase institutional integrity. The bottom row of the schematics model indicates the ways in which this theory can be measured. Catherine Kolkaba used inductive, deductive, and retroductive stages to create her theory. In the inductive stage, she believed her care on Alzheimer's patient within hospice care was partially undefined. She developed the framework for this care and sought to identify further linkages to the way she was practicing. As I stated before, she created a concept analysis on comfort. In the deductive stage, She realized that comfort was related to many other concepts. This was when she decided that comfort was indeed the missing piece of patient satisfaction. Retroductive stage. Institutional integrity was integrated during this stage. Interventions were designed to be congruent with desired outcomes, and this pointed out significant and specific results concerning patient satisfaction. Relationship to research, education, and practice. Learning comfort care is satisfying for nurses, patients, and students. Comfort care is scientific because it concerns a medical diagnosis first and foremost. Comfort care is natural because the general needs of the patient are put first. Comfort is easily assessed in practice and often unknowingly assessed. Comfort increases performance, making nurses' jobs much easier. Comfort outcomes are easily researched, comparing comfort measures practiced with patient outcomes. There are many articles about the research of comfort. Implications for practice. In peri-anesthesia nursing, the needs of the family and the patient are met through comfort care. The nurse may explain the answers to questions or worries prior or after surgery. The nurse may explain post-op pain control measures. The nurse may warm and give pain medicine to the patient prior to surgery. The main reason why the theory of comfort applies to peri-anesthesia nursing is that the nurse is the advocate for the patient's comfort needs. Implications for practice. In hospice nursing, the nurse assesses the psychospiritual, psychosocial, physical, and environmental needs of long-term care patients. Palliative care, which is comfort, may be the only care needed for these patients. Catherine Kolkaba did a very specific research article on hand massage. This article proved that hand massage specifically increases the comfort level of hospice patients. Enhancing comfort of patients alleviates stress and anxiety for family members as well. Clinical scenario. Johnny Walker is an 88-year-old male with terminal pancreatic cancer. Johnny has no family involved in his care. Allison is his hospice nurse, and she is in the home from 7 a.m. until 9 p.m., and another nurse comes in the home for the night. She is extremely dedicated, and her care for Johnny has created a growing relationship with him. One Sunday night, Johnny Walker seemed to be a little more fidgety and irritable than normal. Allison noticed his behavior and decided to stay through the night with the night nurse. Together, they sat by Johnny's bed, reiterating to him the fact that they would do whatever they could for this suffering patient. At 3 a.m., Johnny wept out in agony, speaking of how much pain he was in. Allison and the night nurse administered morphine to him. Johnny then began to express his fears of dying alone and having no one. Allison and her coworker spoke with Johnny that night about the relationship they had created and the presence of love within the room. They assured him that he would never be alone and that they were committed to making this a peaceful experience for him. In the morning, they helped him up to the chair in his room and washed his body and feet. Johnny told them several times how good he felt and how thankful he was for their conversation the night before. He stated that he felt at peace with his state of health and his future outcomes. Catherine Kolkaba spent most of her nursing career caring for long-term and hospice patients. She felt like the care was undefined and strived to better define the compassionate care given to these patients by calling it comfort. Having developed and tested this theory, Kolkaba proved that delivering comfort care to patients creates more positive outcomes for patients and institutions, as well as providing satisfaction for nurses and healthcare team workers. These are the references used for this presentation. Thank you.